Ma'am, I'm not able to see my screen now, ma'am. It went off again.
But your screen is visible here, ma, and you're audible.
Okay, ma'am. But I'm not able to move it also. One second, ma'am. Sorry.
மேடம்
சொல்லுங்க மேடம், சொல்லுங்க மேடம்.
Ma'am, now the screen is
வந்துச்சு, ma.
visible, ma'am.
It has come, ma. You
Okay.
can start, ma.
Okay, ma'am. Okay, ma'am. Very good afternoon to all the respected professors and my dear friends. Myself, Dr. Hema Priya from Madras Medical College. I'll be presenting a case. Moving on to the case details. 73-year-old female who presented with complaints of abdominal pain on and off for the past 1 year. And the abdominal pain was diffuse and dull aching, which was non-specific. And there is no history of hypertension, sweating, palpitation, weight gain, or hirsutism. CT imaging of the abdomen showed a left adrenal lesion, which was measuring about 6.5 cross 4.5 centimeter, which was diagnosed to be incidentaloma, probably myelolipoma. And the endocrine workup was done, where the serum basal cortisol, urine VMA, and 24-hour urinary metanephrines and normetanephrines were all normal. CEA was also within normal limits. And patient undergone laparoscopic left adrenalectomy. This is the MRI image, wherein the left image shows a green arrow, which was the left kidney, which is the left kidney, and the red arrow points towards the suprarenal mass. Uh, and in the next right side image, the blue arrow points a black region where that is the fat component which is being highlighted. There is loss of signal on the outer face imaging of this MRI picture. So in the suprarenal fossa, that is in the adrenal gland, one edge of the tumor shows loss of signal, which is that black area, that is the fat component. So their radiological suspicion was also myelolipoma due to the predominance of the fat component. Then we received this gross specimen, which was circumscribed ovoid mass, and the left one is the external surface, whereas the right one is the cut surface. And in the cut surface, it was homogeneous white in color. In the right edge of the lesion, there is an area here which is blackish surrounded by an yellow component. So this was measuring about 1 cross 1 centimeter. Otherwise, the tumor fully is homogeneous, which is myxoid appearing, and kind of trabeculated appearance was there. So this is the closer image where in the periphery we can see the compressed adrenal parenchyma as well. Moving on to the microscopy, this is the low power view examined, shows interlacing bundles of spindle cells with eosinophilic fibrillary cytoplasm, which is nothing but the Schwannian stroma. And in the next image, we also see clusters and scattered mature ganglion cells. The ganglion cells are nothing but the large cells with abundant eosinophilic cytoplasm and eccentrically placed nuclei with prominent nucleoli. The right top image also we see some lymphocytic infiltrates, which was also seen in the microscopy. Next image and the inset of the ganglion cells, we do see some, an occasional ganglion cell with golden brown cytoplasmic pigment, which is nothing but neuromelanin, which is also a feature of ganglion cell. And in the top right image, we see that the individual mature ganglion cells are surrounded by satellite cells, which again is diagnostic of a mature ganglion cell. And in the lower image, right lower image, we see some multinucleated as well as binucleate ganglion cells. So in this image, we see four images in the screen. And the first top left one is there were some areas of calcification, and the second image in the right is there were some areas of ossification as well amidst the Schwannian stroma. And in the lower image left side, there were some areas of hemorrhage also. And the hemorrhagic areas where some black spots were seen in the gross were all extensively sampled to look for any uh, small round cell or undifferentiated cell component. And in the last fourth image, we do see some entrapped normal adenocortical cells amidst the Schwannian stroma. And this is the normal adrenal parenchyma, and the lower half showing the same Schwannian stroma. And there were also some round blue cells which we had a doubt whether those are all undifferentiated, that is primitive cells or lymphocytes. We proceeded with markers. IHC markers synaptophysin was done, which was not highlighted, and is negative for synaptophysin, whereas in the right image, CD45 highlights those cells. So these were proven to be lymphocytes and not undifferentiated cells or neuroblasts. And S100 was also done to highlight the ganglion cells and the Schwannian stroma. It was diffusely strong positive. Synaptophysin is also positive in the ganglion cells. And any that is undifferentiated component was not there even after thorough examination and extensive sampling. So with this, we diagnosed it as an adrenal ganglioneuroma. And in the first, going back to the gross image, I showed you the image of right edge of the tumor, where there were some black areas surrounded by an yellowish component, which showed this in microscopy. In microscopy, the red color star indicates one component where there were mature fat admixed with hematopoietic elements, whereas in the right half, indicated by the blue symbol, those were all the ganglioneuromatous component, which we described previously. And there were also some lymphocytic infiltrates and lipomatous component. So the distinction between in the both these images, there is a clear demarcation between the myelolipo, that is fat, and the hematopoietic component, as well as in the lower half. In the second image, we see the ganglioneuromatous component. So there is no intermingling of the histological component at the interface. There are two distinct separate tumors. So this is the high power of the mature fat and the hematopoietic element component, where we see tri-lineage hematopoiesis. There were also megakaryocytes, erythroid, and the myeloid components represented in this image. And the final diagnosis we gave was, it was a collision tumor, that is ganglioneuroma mature type, which comes under the favorable histology, and myelolipoma. So it is a collision tumor of ganglioneuroma and myelolipoma. Moving on to the discussion part, adrenal ganglioneuromas or neuroblastic tumors of neural crest origin. As we all know, the differentiation is from neuroblastoma to ganglioneuroblastoma and then ganglioneuroma. It can occur anywhere along the distribution of sympathetic nervous system. That is the sympathoadrenal lineage. The most common site for ganglioneuroma is posterior mediastinum and retroperitoneum, followed by adrenal. Most of them are non-functioning, and so they are incidental findings during imaging than for any other unrelated event. All the children and adolescents are affected, and in adults, it is a rare incidentaloma, which constitutes about 1.5 to 2.9% of adrenal tumors as per WHO edition. The pathogenesis of adrenal ganglioneuroma is there is a proliferation of cells of neural crest origin, and there are two subtypes, that is maturing ganglioneuroma, and another one is mature ganglioneuroma. The prognosis of this ganglioneuroma is excellent following the adrenalectomy, and very rare cases, this transformation of MPNST has been reported. This is the classification and grading of neuroblastic tumors. International Neuroblastoma Pathology Committee has classified this based on the Schwannian stroma, whether it is dominant, rich, or poor, into neuroblastoma, ganglioneuroblastoma, and ganglioneuroma. Here are the arrow points towards the mature type, which we reported. It is mature ganglioneuroma, where we see mature ganglion cells and Schwannian stroma without any neuroblast or neuropil. And it has also classified into favorable histology and unfavorable histology based on age, grade of the tumor, as well as the mitotic karyoretic index. Here again, the arrow points that any age, the ganglioneuroma, mature or maturing type, comes under favorable histology only. And thus this tumor is of excellent prognosis. This is International Neuroblastoma Risk Group Staging System, where the stages are L1, L2, M, and MS based on whether it is localized or metastatic. Here again, the ganglioneuroma mature type or the maturing type will be coming under either L1 or L2, that is localized tumor. These are the other immunohistochemistry which can be applied. S100 and synaptophysin has been done in our case, and neurofilament, NSE, and other markers also highlight those ganglion cells on the stroma. Moving on to the differential diagnosis part, the ganglioneuroma main differentials would be ganglioneuroblastoma, As in our case, also we suspected some lymphocytic cells to be neuroblastic cells, but the marker did not prove it. So always to have to take extensive sampling to exclude ganglioneuroblastic component. There will be undifferentiated small cells amidst the mature ganglion cells and the Schwannian stroma. And the second differential would be complex pheochromocytoma with ganglioneuroma, where again we see two components in the image, and the top one representing the organoid pattern of the cells, which are diagnosed to be pheochromocytoma, and the lower one show the ganglion cells. So it is composite pheochromocytoma with ganglioneuroma. Other two differential diagnoses include neurofibroma, where we see spindle cells admixed with collagen. Here we again don't see ganglion cells, and that's the difference. And schwannomas also we see hypocellular and hypercellular areas with Verroque bodies. Here again we don't see ganglion cells. So these are all the differential diagnoses considered for ganglioneuroma. These are the two gross images of ganglioneuroblastoma. Ganglioneuroblastoma, we have two subtypes. One is intermixed, another one is nodular. The left image is intermixed type, where the gross picture will be mimicking the same as that of ganglioneuroma, but there will be some microscopic nests of neuroblastic cells. In gross, we will not be able to see any nodule. Whereas in nodular type of ganglioneuroblastoma in the right image, we'll see more than or equal to one nodules, and that should be sampled and to look for neuroblastic component. So this is all about adrenal ganglioneuroma. Now moving on to myelolipoma. Adrenal myelolipoma, it occurs in 5th to 7th decade. Majority of them will be asymptomatic and non-functioning as that of ganglioneuroma. 5% tumors has been reported for bilaterality also. They are also mostly incidentalomas, constituting about 3% of adrenal tumors. This is the second common benign tumor after adrenocortical adenoma. Extraadrenal presentation can be seen in retroperitoneum. And adrenomyelolipoma, there has been association with adrenocortical tumors accompanied by Cushing syndrome or with congenital adrenal hyperplasia, and rarely with ganglioneuroma, as in our case. Adrenocortical neoplasms, cortical hyperplasia, and even normal adrenal gland can develop a small component of lipomatous or myelolipomatous metaplasia. But in our case, there was a clear distinction between the two components. They were not thought to be metaplasia. They are two distinct tumors. And even the genetic study can help in this. X chromosome inactivation has been studied and which supports the clonal origin. And this is not a metaplastic component, which we saw in this case. The differential diagnosis for myelolipoma considered were angiomyolipoma, lipoma, liposarcoma, and myeloid sarcoma. The first three differentials will not have the myeloid component, whereas in myeloid sarcoma, there will be a blast apart from the trilineage hematopoiesis. So last few slides about the adrenal collision tumors, which was our case. So the collision tumors are mainly, there will be two distinct separate tumors with separate borders, and there will not be any histological admixture at the interface. Here again, in the collision tumor, reporting collision tumors, pathologists play a vital role in this. As clinicians or as clinically or radiologically, one component could be missed as well. So histopathology plays a very important role in diagnosing collision tumors. The common adrenal collision tumors combinations include adrenocortical adenoma and myelolipoma, adenoma and even metastasis. Others like adenoma with hemangioma, adenoma with pheochromocytoma, adrenocortical carcinosis, and even myelolipoma with Hodgkin lymphoma. So this adrenal ganglioneuroma with myelolipoma is a rare combination, and there are, as per our knowledge, there were only 4 cases reported so far: adrenal ganglioneuroma and myelolipoma combination. These are the 4 articles, case reports which were reported, and among these one was like the 69-year-old female who had a renal cell carcinoma operated. There that was reported to be clear cell RCC with sarcometal cell type, and the adrenal received showed mature ganglioneuroma with myelolipoma. So this was also a rare case report, one case report, and overall there were 4 case reports of this rare combination. So the final take home of my presentation would be the collision tumor of ganglioneuroma and myelolipoma. They originate from different parts of the adrenal gland. That is, the ganglioneuroma is from the medulla.
MU values நீங்க எனக்கு தெரிஞ்சு இருக்காது, நான் கேட்கவே இல்லை. பட் நான் ஓகே போட்டு நெக்ஸ்ட் டைம் கண்டிப்பா வேணும். சிவி பர்சன்டேஜ் எஸ்டி பண்ற மாதிரி MU வேல்யூஸும் டிரைவ் தான். அது பண்ணிட்டு மானிட்டர் பண்ணணும். எஸ்ஏ சார்ட் பண்றது சிவி எம்டி.
ganglioneuroma, the collision tumor, ganglioneuroma will originate from the medulla part, whereas the myelolipoma is from the adrenal cortex. So this combination of adrenal ganglioneuroma and myelolipoma is extremely rare and unusual. So most of them are hormonally silent, hence it is clinically challenging as well. And the definitive diagnosis relies on postoperative histopathological examination. In a case of ganglioneuroma, as I said previously, extensive sampling is to be done to exclude this neuroblastic component, especially in the gross. If we see any hemorrhagic nodule or soft friable areas, we have to sample that part to exclude the neuroblastic component. And immunohistochemistry aids in diagnosing the neuroblastic component in difficult cases. These are my references. Thank you. I thank my professors for giving.
Hemapriya, very good presentation.
Thank you, ma'am.
And I just wanted the gross was, you're saying the other component of myelolipoma. How
Yes,
was the
ma'am.
gross? How was the gross? Because we had just received one incidental finding.
Okay, ma'am.
Adrenal incidentaloma. It was
Okay.
not like this for me. It was like a very soft, like a fat and a little brownish the cut
Okay,
surface,
ma'am.
very
Okay.
soft. It was not even able to take a section and a capsule separately, and they
Okay,
have
ma'am.
sent it as a adrenal incidentoma. So I was expecting something like yours, but unfortunately, I don't know. A few ganglion cells were there, and the rest of the cells looks like a fat only.
Oh, okay, ma'am. Here in this gross,
I,
that black areas represented those hematopoietic components,
Yours
ma'am.
is okay. For,
Okay, ma'am.
for us, it is only the tissue which is separately taken and sent.
Okay, ma'am. Okay.
I'm still breaking my head to come to a diagnosis. Anyway,
Okay.
yours was an excellent, extensive, good presentation,
Thank
which
you,
a
ma'am.
rare combination you have presented. Since we have also received an incident, Roma, I thought something will come. I hope
Okay,
I'll
ma'am.
take a rebit and see.
Okay, ma'am. Sure, ma'am. Thank you,
Valar,
ma'am.
Valar,
Ma'am,
can you
ma'am வரல மேம் வரல எனக்கு
வரலையா?
வரல அதான் நான் சொல்றேன்.
நான் திருப்பி சொல்றேம்மா, நீங்க அடுத்த கேஸ்
Emma, Emma, show
Ma'am,
the first picture, ma. Show the first picture, grass picture.
gross
Grass,
picture.
grass.
Yes, ma'am. Yes. Yes, ma'am.
That dark area on that
இந்த
right side.
செகண்ட் இமேஜ்ல இந்த மார்க் பண்ணிருக்கேன்ல மேம் ரெட் கலர்ல
Okay.
I don't see my mark and the right edge of the tumor there is a black
Okay.
area surrounded by the yellowish component, ma'am.
Okay. Okay.
இன்னும் கொஞ்சம் வர சொல்லுங்களேன், எனக்கு இந்த ஓப்பன் ஆக மாட்டேங்குது இதுல. ஐயோ, இந்த போலி அங்க ரீச் ஆகும்.
With Ariel's permission, can I go ahead with my presentation?
Presentation. Okay, ma'am. Yes, ma'am. So, Doctor, ma'am, one nimsha. Dr. Hema, thanks for that presentation. That was a beautiful presentation. So we go on to the next.
Valar,
Okay.
Valar, am I audible, Valar? Selvavi.
Yes. சொல்லுங்க மேடம் சொல்லுங்க.
That's good afternoon. I just want to add one point to Elvidi madam's question. Ideally, we should not see any other components if we look at the tumor like myelolipoma. In addition, if we see any components like ganglion cells or a small cells resembling the lymphocytes, we have to take more bits. So more number of bits to be taken to exclude any additional tumors like collision tumors. Ganglion cells should not be seen in any part of the adrenal gland.
Okay, ma'am. Okay. Yes, ma'am.
Thank you.
Okay.
Nice presentation for Hema. Thank you.
Okay. Thank you so much, ma'am. Thank you for the inputs. And so we go on to the next presentation. Ma'am, Sita Lakshmi, ma'am, you can share your screen.
We are having only 2 spotters.
Yes, ma'am.
Mainly for the upcoming pathologist and the postgraduates.
Hold on. One more spotter. Impana தெரியாதல. We close on off பண்ணினாது அரே.
I hope my slide is visible, ma'am.
Yes, Dr. Impana, please continue.
A very good afternoon, everyone. So we'll be presenting two spotters today. First is a case of a 1-year-old male who came with increased blood nitrogen, elevated creatinine, anemia, bone marrow aspiration and biopsy was sent to us. So this was the aspirate image. We could see some grayish deposition in the bone marrow aspirate with surrounding some histiocytes. Otherwise, erythroid series, myeloid, and megakaryocytes were normal for the age, and there was no erythropoiesis or any other increased blasts or anything. So when we use the polarized light, we saw like this refractile, clear, fan-shaped deposition in the bone marrow aspirate. And also we received the biopsy, which shows linear tubercular bony, medium bony tubercular with intervening normocellular marrow for the age. And in the marrow also, we could see grayish fan-like deposition of some crystals, which was refractile on the polarizing sheet which we used. So when we asked for the history, this was a case of hyperoxalosis of bone marrow. This patient, genetic evaluation was already done for the patient, and patient had the gene mutation in AGXT. So this is an autosomal recessive disease where there is the AGXT, because of that mutation, there is deficiency of alanine glyoxylate aminotransferase enzyme, which will break glyoxylate into glycine. So hence all the glyoxylate will be converted to oxalate, and it will start depositing in all the organs, like initially kidney. That's why patient has come with chronic kidney disease, small kidneys. Also, this deposition we can see in the bone marrow. So this was this incidence is very rare. 1 to 3 million people we see this condition where there is hyperoxalosis of bone marrow due to AGXT gene mutation. So there are 3 types of this primary hyperoxaluria. The type 3 is the least severe type. Type 1 is the initially detected within 1 year. We detect type 1 disease as the patient presents due to extensive oxalate deposition.
Actually, this was I don't know how many of you remember when we had a chapter meeting earlier, not like aesthetic pathology. I had presented a case of oxalate crystals in renal biopsy. In a nephrectomy specimen of a CKD kidney, I had reported, and that was Dr. Edwin's case. So that Edwin, I think he even presented that in his nephrology meet, and this is actually the second case that we have seen here after a long gap. So one should be actually in the histopathology, one should be very, very careful, and a careful scrutiny is important to identify these crystals which we actually earlier we missed, And then we wanted to see it under polarized, and with the polarized filter, and we saw, then we detected all this, we went back to the histology, and then we could detect all these crystals. So careful scrutiny is a very, very important thing for everybody to remember to look for these kind of crystals. The clinical diagnosis actually they said was cystinosis, but cystine crystals morphologically are a little different from oxalate crystals. So here it is very, very classical and a very rare involvement of bone marrow. So when you have a bone marrow involvement, one should think of a systemic oxalosis. So that means everywhere this child will have a deposits of this because of the genetic problem, and the enzyme pathway is different. So that you have to bear in mind. Once the bone marrow is involved, it will become a systemic disease. Okay. The second case is also a very, very interesting case. This was actually an elderly male who came with a melena history, and a routine endoscopy was done, and this was what they found, and this is the endoscopic picture. You can see everything is normal except the diffuse pigment deposits in the duodenum, and you can see the black spots in the duodenum. The endoscopic picture down. So they had a clinical diagnosis, but then I thought I will mask it so that you shouldn't be carried away with this. Can anyone of the upcoming pathologist or postgraduate tell me what could be the reason for this? What could be the reason for this black pigmentation? Has anybody seen this kind of an endoscopy picture? Okay, let us go to the biopsy. See, biopsy, you can see the duodenal mucosa, and in the lamina propria and in the papillary core, you find some brownish black pigment in the histiocytes. That was the only positive finding in this. Otherwise, the duodenum was quite normal. There was no abnormality in the villi or in the villi ratio or whatever morphological organization you find. You can even find the goblet cells. But so we had to do a special stage to know what kind of a pigment this is. And the serum ferritin was high in this patient, as you can see here. And we did a pearl stain, and that is beautifully positive. So this condition is called pseudomelanosis. Why is it called pseudo? Because it is not melanin pigment, but it resembles the melanin pigment because of the color. And please remember that it is extremely rare in duodenum. And it is because of the deposits of iron and hemocysteine macrophages and long-standing iron intake, as it happened in this patient, or GI bleed, or medications with ferrous sulfate. All this can induce this. An endoscopy of brownish black pigment in the jejunal mucosa. Actually, it was diagnosed in the endoscopy itself. The endoscopist told me that this is a pseudomelanosis of the jejunum. Madam, it is very rare. Please confirm your biopsy. Now, the thing is, it has to be differentiated from the other conditions like melanoma. Very, very important. There is no specific treatment unless the patient has some symptoms. But more common than this is the melanosis coli. I'm sure all of you would have definitely seen at least the exam. See, all these are actually exam slides. Even your myelolipoma is an exam slide, and melanosis coli is also an exam slide. Now, here it is usually seen in the elderly individuals because of their constipation. They use laxatives. And that contains anthraquinone, and the pigment here is actually the variant pigment of lipofuscin, which is from the cellular waste products accumulating in the cells. So this will be pearl negative, and very rare instance of colonic polyp or adenoma has been reported. And so, if being an elderly patient, they may have to be followed up. That is important. What is important is the lifetime changes, fiber diet, plenty of water intake. All this will definitely revert this condition to the normal. So I thought that these two are not a very commonly encountered cases. So I thought I will just share them with all of you so that awareness can be created. Questions? Okay, Ariel, you can go ahead with the next case.
Go to the screen. Dr. Vidya, are you ready?
What about Ariel?
Ma'am?
Ariel is an answer.
இல்ல மேம் மேடம் there's some hitch in the sharing மேம் கொஞ்சம் டைம் ஆகும் ஒரு கொஞ்ச நாள்.
Sensing mode.
Dr. Vidya from Rela, are you ready?
Bluetooth mode.
Hello, ma'am. Yes, ma'am. I'm ready. I'll share my presentation.
Yeah.
Just give me a moment.
Well, I'm still not able to get it.
Ma'am, or 5 minutes, ma'am. We'll get it at the earliest possible.
Okay.
Pleasant afternoon to all. I've shared my presentation, ma'am. Is it visible?
Yeah, ma'am. It's visible. You can continue.
Okay, ma'am. I proceed with the presentation. So, I'm Dr. Vidya Lakshmi, consultant pathologist from Rela Hospital, and this case was reported by Dr. Gauri Priya. Brief clinical details. So, 76-year-old female, she presented with abdominal pain, and on preliminary investigation, she was investigated in a hospital elsewhere. She presented with a solid and cystic mass near the midline, and on imaging, there was a supravesical mass with urinary bladder dome infiltration. So, she was taken up for surgery, and excision of midline mass with the bladder tissue was done. was the intraoperative finding, and this is the cut open urinary bladder. And in the dome, here we can see a lesion which is present, and this is the mucosa of the dome of the bladder. And this was the excised cystic lesion on the outer aspect, and this is the part of urinary bladder which was removed, and the circled area is the mucosal area of the urinary bladder. So this was the other operative specimen on the outer aspect, and this area which is circular, this is the cystic lesion which was adherent to the dome of bladder. After fixing, these are the images, and here we received a cystic lesion which thickened wall, and it was approximately measuring 8 cross 7 centimeter. Along with that, we received abundant gelatinous mucoid material in the container. And on cutting open, here we can see the wall is thickened, and there were multiple mucin-filled lockings within the wall of the cyst area. And predominantly, the specimen was of the cyst wall excision with fibrosis, and there were gritty areas of calcification. And focal areas showed urothelial, probably mucosal lining, probably from the bladder tissue that could be identified. Moving on to the microscopy of the section. So this is a low power image to show the excised cyst wall. Here we could find proliferation of epithelium which is thrown into papillae and in glandular architecture with abundant extravasated mucinous material. So there were these glands which were seen through the fibrous wall with abundant mucinous material, and the architecture were areas they were plain and they were a single layer of epithelium. In majority of the area there were papillary formations and tubular architecture with abundant mucinous material. So this is a scanner view image to show that there are these cystic spaces which have some denuded areas, and in the areas we can find the glandular epithelium. And this is the outer aspect with the bladder wall, and this is the cyst wall with abundant extravasated mucin that's present. Going to the high power, here we can see the glandular architecture, and the lining epithelium shows an intestinal pattern of differentiation with mild stratification of the nuclei. So here are some papillary foldings of the lining epithelium, and glandular architecture can be appreciated, and the underlying aspect shows a fibrous wall. This is higher magnification to show the nucleus stratification with variable amounts of mucin that is present. The nucleus was penicillate. There were no high-grade nuclear atypia on extensive sampling. These are the other areas where the glands showed low-grade dysplasia. And in the adjacent areas of the cyst wall, there were lots of fibrosis, inflammatory infiltrates with foamy macrophages, and foci of calcification was also noted. This is an image to show the urothelial lining that was present focally. The adjacent area was showing ulceration, but the focal urothelium without any dysplasia can be identified. With these findings, we were thinking of a mucinous lesion occurring in the bladder, infiltrating the dome, and we ran a panel of immunohistochemistry markers. And so far, after extensive sampling, we did not find any desmoplastic reaction or a destructive pattern of growth. So in immunohistochemistry, the lining epithelium was diffusely positive for CK20. It showed intestinal differentiation with diffuse positivity for CDX2. Amacor expression was noted. Beta-catenin showed a membranous pattern of expression. There was no nuclear pattern of expression. CK7 was negative in most of the areas. There were patchy positive areas in very focal areas of the lining. GATA3 was negative. So this was the immunohistochemistry panel. I've summarized it here. So to summarize the case, here we have a mucinous cystic lesion which has glandular proliferation with abundant extravasated mucin which is going through the walls of the bladder and displaying a low-grade dysplasia. So with the immunohistochemistry findings of being CK20, CDX2 positivity and negative for GATA3 and other markers, there was intestinal differentiation. So we considered this diagnosis as cystic neoplasm of low malignant potential. After follow-up for 3 months, the patient was kept under close observation and she did not present with any other complaints and she hasn't received any further adjuvant therapy or additional treatment. There has been no recurrence or other complaints from the patient. So this is about our case. Follow up with a brief discussion for the same. So the urachus is basically a remnant of the allantois, and it's a fibrous connective tissue which connects the umbilicus and the anterosuperior aspect of dome of bladder. Usually it obliterates at birth and becomes the medial umbilical ligament. So whenever there's a failure of involution of the structure, we have a urachal pathology. And neoplasms occur in it when there is a neoplastic transformation of the remnant urachal tissue. So the urachus is usually lined by urothelium, and it can also have glandular lining with mucinous epithelium, and mucinous tumors can arise from this site. Coming to urachal mucinous tumors, they are exceedingly rare, and among literature, they represent about less than 1%, 0.17% of all bladder neoplasms. And from literature, according to different case series, around 70 urachal neoplasms have been reported, 26 of which have been mucinous cystic tumors of low-grade malignant potential. The morphologic spectrum of these all parallel with appendiceal neoplasms and that of ovarian intestinal type mucinous neoplasms. So for this to distinguish and to prove that this is of urachal origin, if the normal remnant urachal tissue is not present, usually we have to correlate with the imaging findings to see that where the location of the lesion is present. Usually it presents as a midline lesion infiltrating or present along the dome of urinary bladder. And the histological features give a clue towards the mucinous differentiation, and the degree of dysplasia has to be graded, whether it is low grade or if there is high grade or an intraepithelial component is present or not has to be documented. And invasive adenocarcinomas will usually have a desmoplastic reaction and destructive pattern of growth. An exclusion of other primary tumors is required. For this, we require intraoperative correlation and imaging findings. Among these, low-grade malignant potential mucinous cystic tumors, they are considered as borderline tumors, and they don't recur if they are completely excised along with the bladder tissue. And mucinous cyst adenocarcinomas, on the other hand, they have poor prognosis, and therefore, in any of these mucinous tumors, external sampling is required to rule out any intraepithelial or an invasive component.
After you've taken about...
Ma'am? Okay, so there is a proposed classification of granular neoplasms of the urachus. So in WHO, they have combined most of these entities together. So if you see benign mucinous cystic tumors, that includes cystadenoma, which usually has a single layer of lining epithelium. When there is epithelial proliferation, we have the borderline category, and that is the mucinous cystic tumor of low malignant potential. And this displays low-grade dysplasia. There should not be any intraepithelial component in this. Malignant spectrum of tumor includes mucinous cystadenocarcinoma with microinvasion or frankly invasive carcinoma. And among the malignant non-cystic neoplasms, we have mucinous adenocarcinoma and other adenocarcinomas which can have enteric type differentiation, mixed features, and not carcinomas which don't fit into mucinous category. So this is a proposed classification. So to summarize, the urachal neoplasms, they are rare neoplasms, and mucinous tumors can range from cystadenoma to invasive mucinous adenocarcinoma. So for making the right diagnosis, we need to compare the morphology and immunohistochemical profile, and extensive sampling should be done to rule out an invasive component. And there's always an overlap of these profile with ovarian and appendiceal or colonic tumors. So this warrants that complete imaging workup is done to rule out any other lesions in these sites, so that we can be sure that this is a primary tumor arising from the urachus. Thank you.
Thank you, Dr. Vidya. What about the prognosis of these tumors?
Okay, ma'am. So low-grade mucinous cystic neoplasm, it's considered borderline, ma'am, and this has low-grade dysplasia. And usually the treatment for this is complete excision of the cyst along with the excision of bladder wall, whichever is adherent to it. So in articles that I read, it's mentioned that resection is completely curative and patient does not require any additional therapy. And they can follow them up and see if there is any recurrence. But in the documented literature, there have not been any described recurrence in low-grade malignant potential tumor. For this to be sure, sampling should be extensive and adequate so that we rule out an intraepithelial carcinoma component.
Thank you, Dr.
Very
Vidya.
nice point, See, we have had a few cases of mucinous tumors of the bladder. See, whenever you come across, normally we see urothelial carcinoma. Normally we see urothelial carcinomas of the conventional type which we normally report. But whenever you come across this kind of mucinous tumors, especially in a female, you have to definitely rule out a ovarian pathology. And whether it's a female or a male, you have to rule out a colonic pathology. That is a very, very important point to remember before you venture upon a diagnosis of a urachal malignancy. So that is a very, very important point which you also stressed. So that is a main point that I want to highlight here, because you have to rule out a metastatic deposit from other lesions before you think it is a primary mucinous neoplasm of the bladder. So that is the only point that I wanted to stress. It was a good case.
Thank you, Dr. Vidya. So so it was a nice case, and next case presentation will be by our Elviri madam. Ma'am?
It's ma. Before, am I audible?
Yes, ma'am. Yes, ma'am. You can continue, ma'am.
Yeah. Good afternoon to all the professors and senior professors and juniors for this presentation. And I would like to tell, before starting my presentation, we always consider or worry about the malignant cases when case comes to us. But sometimes a very important clinical diagnosis along with our biopsy. A simple case may be a metabolic disorder like thing can be highlighted by our biopsy and our evaluation. This is just a introduction I wanted to give. We cannot always think of malignant tumors. Some metabolic conditions we come across, we should not miss in our clinical cases. Next slide. The presentation was 61-year-old female with bone pain and fatigue with bone marrow sclerosis, diffuse bone sclerosis by the hematologist, Dr. Margaret. She sent this biopsy material, and to rule out any hematologic malignancies, her clinical scenario. Next slide. So the investigations, the biopsy specimen sent to me on 17th September. But when I asked her to review the other investigation she has done in view of why she thought of malignancy in her case. And then she said she has done this PET-CT and osteolytic lesion focally, and she did all investigations to rule out a myeloma panel, and then she did parathormone. Then only the whole picture started different. Now you have seen the investigations done on 27/8. It was CBC was normal, calcium was low, and other parameters normal. Liver function shows alkaline phosphatase 397 and GGT 69 and parathormone 1718 picograms and vitamin D 9.7, and urine appears to be RBC and protein and sugar was present. Next slide. So when we received the specimen by bone marrow specimen, we wanted to get it from the clinician. Then that time the PTH was reduced, calcium was 8.9, phosphorus 3.4, alkaline phosphatase also 454, and PET-CT there was an osteolytic lesion. Next slide. Next slide, ma. So the microscopic picture, since she was, she wanted, Margaret wanted hematological malignancies. I was more concentrating on the marrow elements which were seen within the specimen given. At last, when I was asked, when I went back into the history and why she wanted this hematological malignancies in this case and what other investigations done and osteolytic lesion, then it just clicked in my mind. So when I went back to the slide and again I reviewed the slide. Next slide. Next, there was many osteoclastic giant cells were seen near the bony trabeculae and the megakaryocytes were increased, but no other abnormal cells in the marrow. This osteoclastic giant cells given the clue for the diagnosis. Next slide. Next slide, ma. Yeah, we just described the section. Then at that time, I asked her to review the renal panel and then come to a diagnosis. This is a picture I have given, the osteoclastic type of giant cells with suggestive of secondary hyperparathyroidism and advised parathormone level and other relevant parameters for a confirmation. Next slide. So then in one more slide. One more slide. Before that, investigations early. So 1 minute, ma. You just before going to the discussion, I just wanted to give you the investigations. I told you the parathormone level was considerably given. மாத்தாதீங்க பெரிய மாத்த அது கொடுத்துட்டேன் sorry. Yeah, sorry ma. Valer, please give the discussion. Please see the discussion. I'm not able to see the discussion, ma.
Ma'am, inge discussion Ankita madam the slide theriyadhu. We can see the slide, ma'am.
Yeah, I'm not able to see. That's why I'm asking. Yeah, okay. The final outcome was secondary hyperparathyroidism was a diagnosis. A simple example of the body, other hormones which are more important and the normal level of renal function test which confirm this diagnosis. For a discussion, the parathyroid glands as an undergraduate level and a PG level, everybody knows the role of parathyroid hormones in the maintenance of the calcium level in the to control the nervous and the muscular system and how much calcium is in our bone, and we have to estimate the vitamin D level, calcium and phosphorus and parathyroid hormone in this case. Next slide. Yeah, so this everybody knows PTH secreted by chief cell and parathyroid glands as a peptide, and concentration with increase in the blood, and calcitonin, it acts like to decrease the calcium concentration. Next slide. Yeah, we have a picture which is going to give you the sensor of the gland and the receptors which are acting on the cell membrane to eliminate the increase calcium in the extracellular fluid, and then when it is low due to the unbound. Next. Yeah, this is a diagrammatic representative to see how the receptor binds the calcium and what happens to inhibition of PTH, and likewise the low calcium level, how it moderates the parathormone action. Next. Yeah, this is again one more representation how all the vitamin D, calcium from the intestine and get the reabsorption of the calcium from the renal parenchyma. Next slide. So the effects of PTH effects on the bone, rapid effect, it stimulates the osteoblast to pump the calcium ion to the higher concentration into the ECF, and longer time, the PTH stimulates the resorption and osteoblast causes them to express a signaling molecule that activate the osteoclasts, which were seen in our case from the presence of osteoclastic giant cells in the bone marrow bone marrow biopsy material. Next slide. So the PTH effects on kidney, I have already told you. One more thing, the production of vitamin D, 125 cholecalciferol are made to effect because of the lack of calcium absorption from the diet. So hypocalcemia again stimulate the high level of PTH secretion termed secondary hyperparathyroidism, because the problem which causes the hyperparathyroidism is the kidney, not the parathyroid gland. So secondary parathyroid is treated by administering vitamin D and calcium supplements. Next. Next slide, ma. Yeah, next slide. This is what I told you already. Next slide. Repeat it. Next. Yeah, the stimulators of producing the hyperparathyroidism are decreased calcium, mild decrease of the magnesium, and increase in serum phosphate, and which is also to complex with calcium forming calcium phosphate, which reduces the stimulation of calcium sensitive receptors that do not sense calcium phosphate, which triggers in increasing the PTH. This is what happens in our case. Inhibitors, they increase the serum calcium level and severe decreases in the serum magnesium, which also produces symptoms of hypoparathyroidism such as hypocalcemia. Next slide. So, before coming to closure of the completion of this discussion, primary hyperthyroidism is a result of gland hyperplasia, commonly due to a tumor adenoma, which secrete the hormone without proper regulation. Whereas secondary hyperparathyroidism, where the problem lies out of the parathyroid gland, which excessive secretion of the parathyroid hormone by the chronic kidney disease, and kidneys were unable to reabsorb calcium and blood level will fall, stimulating the secretion of PTH to maintain the calcium level in the blood. Next. So the take home message, the chronic kidney disease, 10% of the global population are affected, and one of the worst complication is the secondary hyperparathyroidism, which increases the bone deformities and cardiovascular events, and mortality is increased because of the vascular calcification. Next, the treatment is very successful if you find the diagnose the condition in time. The phosphate binders, vitamin D receptor activators, and calcium mimetics. If fails, the medical treatment fails, surgically you can do parathyroidectomy and thermal ablation are considered. Next, thank you. For a change, I wanted to present this metabolic disorder commonly we encountered in our day-to-day presentation, which should be useful for our pathologist forum. Am I audible, Valer?
Thank you, ma'am. Ma'am, you're very audible. Thank you, ma'am.
Sorry. Last minute workup and I was little unwell. That's why I did it all in the last minute. I'm sorry I worried you. And in contrast to normal malignant diseases and tumors, I thought this is a simple case which will highlight the importance of doing. And the hematologist should not have defocused us from the area of diagnosis. I was not looking at the bony trabeculae at all. I was looking into the marrow elements to find what fault with the hematological malignancy she is suspecting. Then only the whole issue was resolved. Anyway, just want to highlight and bring to the notice of the young junior people who come across cases like this. Thank you.
Thank you, ma'am. Thank you for presenting the case in spite of your ill health, ma'am. Thank you so much. That was a nice presentation. Ma'am, the case is open for discussion.
Sita போயிட்டாங்க கிளம்பிட்டாங்க. Anyway, this is only the clinicians, when we, an interaction with clinician is very important for the final diagnosis. If I could have called, without calling Margaret, I wouldn't have confirmed the diagnosis. And the doubt patient was suffering from the August, and end of September only she became normal after finding the diagnosis. So the interaction with the clinician is very, very important. That's what the moral of the
Story.
case report.
That's a rare case.
Yes.
Case lab. And Australia's James if there you have to think like the differential diagnosis. And as we say, we should go along with the clinician to find out the cause also. So it's an eye opener. Good case.
Yes, that is what I wanted to bring it to the City Pathologist Forum. Because we never, I was about to, I was very distressed. What is this lady has sent this for me to find out a hematological malignancy in this light? Then I asked her, what made you to do parathormone? Then she said, myeloma, she did the panel and everything came to normal. And then she did a parathormone was very high, madam. Then I said, madam, it is only a secondary hyperparathyroidism. But after finding out the osteoclast, which was close to the trabeculae, I think I focused in the slide, which whether you are able to see. And then the eye opener of the case was made it easier for me. Thank you, everybody who listens to this case presentation. Anyway, you will be presenting you will be sending the record of cases, isn't it? Valer?
Ma'am, yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
You will be sending the...
Yeah, Kandipa, ma'am. Yes, ma'am. Yes, ma'am.
Thank you so much.
Okay, ma'am. Thank you, ma'am. So we go on to the next presenter, Dr. Maithili from Stanley Medical College.
Interesting.
Good afternoon, doctor. Good afternoon to all. I am Dr. Maithili from Stanley Medical College. My presentation is 14-year-old male came with complaint of acute onset came with complaint of acute onset headache and giddiness and altered sensorium. CD brain source, well-defined hyperintense lesion measuring 6.5 cross 6 centimeter with a hypo intensity in internal area in the body of the left lateral ventricle. It extending into the parietal and temporal bone and it causing the surrounding edema and midline shift to right. Bone defect also noted in the right parietal bone. Sulcal hyperintensity noted in the frontal bone. This is the image shows the intraventricular hyperintense lesion with the internal hypointense areas. It causes the infiltration into the left temporoparietal lobe and it causes erosion in the parietal bone. And sulcal hyperintensity also noted. And intraoperative findings shows intraventricular blackish tumor mass extending into the temporoparietal region and subarachnoid space. It partial resection only done due to heavy bleeding. Clinical differential diagnosis for choroplexus papilloma and ependymoma. Received multiple blackish soft tissue fragment, largest measuring 2 cross 1.8 cross 0.5 centimeter, smallest measuring 0.5 centimeter in diameter. And microscopic view, scanner view shows the areas of necrosis. Scanner view shows areas of necrosis and tumor cells arranged in diffuse sheets and perivascular pseudo-rosette formation also seen. 10x view shows the tumor cells are having intracytoplasmic brownish pigmentation and extracellular pigmentation also seen. And 40x view shows the moderate degree of atypia and mitosis also seen. Based on the histopathology, we arrived at following possibility are considered: pigmented ependymoma and CNS embryonal tumor and melanocytic tumors. So we did the S100 and EMA to rule out the pigmented ependymoma and synaptophysin for the melanocytic medulloblastoma and S100 for melanocytic tumors. Second line panel, we did HMB45 and CD56, CD56 negative and HMB45 positive. S100 positive in diffuse strong positive in tumor cells, HMB45 positive in the cytoplasmic positive in the tumor cells, Ki67 index is 30 to 40%. So based on the histopathology and immunohistochemical examination, we arrived possibility of primary melanocytic tumor of CNS and metastatic deposit from the cutaneous malignant melanoma. And then we discussed with the neurosurgeon and they told patient had the hyperpigmented lesion over the scalp and left forearm. So we suggested the PET scan and biopsy from the pigmented lesion to rule out the metastasis from the cutaneous melanoma, and the patient referred to the NIMANS for further evaluation and workup. Go to discussion part. Pigmented lesions of CNS are melanocytic medulloblastoma and pigmented ependymoma, malignant melanocytic nerve sheath tumor, meningeal melanocytic tumor, metastasis from the malignant melanoma. Melanocytic medulloblastoma and pigmented ependymoma ruled out by the IHC marker. HMB45 and S100 positive in all three tumors of melanocytic meningeal melanocytic tumor, metastasis from the malignant melanoma. In malignant melanocytic nerve sheath tumor, usually arising in the paraspinal nerve root, it having the histological feature of short fascicles and seeds of spindle shaped cells with polygonal cells forming the syncytial and palisading pattern, and the somoma bodies are seen. It is in our case, we didn't have these findings. Then meningeal melanocytic tumor, it is very rare tumor arising from the leptomeningeal melanocytes. It is very aggressive. Prognosis is better than the metastasis from the cutaneous melanoma. It have two types. One is diffuse, another one is circumscribed. Each having the two subtypes. In circumscribed lesion, melanocytoma is benign, well circumscribed melanocytic tumor. Melanoma is the infiltrating malignant melanocytic neoplasm. Diagnostic criteria for the diffuse meningeal melanocytic neoplasm is diffuse multifocal neoplasm with invasion of CNS parenchyma and marked nuclear atypia and necrosis indicate the meningeal melanomatosis. Absence of the invasion and atypia and necrosis indicate the melanocytosis. In desirable criteria, in children, it is usually associated with the NRAS mutation and rarely associated with the BRAF mutation. Meningeal melanomatosis is very rare condition. Population-based incidence is difficult to estimate. It is usually associated with the neurocutaneous melanosis. Distinction from from the metastasis may be impossible by using only imaging and microscopic feature alone. Additional molecular testing needed to diagnosis the myelomatoses differentiated from the melanoma metastasis. Mutational analysis are GNAQ, GNA11 mutation usually associated with the melanoma-matosis. It is very rare and very aggressive tumor with a dismal prognosis. Metastasis from the malignant melanoma, it is the third most common neoplasm metastasis to the brain. It usually diffuse and multifocal. Only 8% of cases is circumscribed, mostly located in the gray white matter junction. It forming the contrast and enhancing multiple lesion. It having the atypia with a prominent nucleoli associated with the BRAF mutation. This is a case report published in the Journal of Surgical Case Report. It explained about the diagnostic challenges from the melanoma-matosis from the metastasis from the melanoma. We have to assess the biopsy from the cutaneous pigmental lesion and mucosal lesion, and have to examine the ophthalmic examination to rule out the uveal melanoma. These are my references. Thank you.
Very good presentation. And I have seen cases even sometimes when we were not able to see a primary at all. The primary lesion will be very flattened lesion in the sole of the foot or other sites which are commonly seen as a primary. Even when we look for a primary site, may not be evident at all. So only by presence of this markers and this melanoma. Very nice. Valar?
Yes, ma'am. Yes, ma'am. If there are no questions,
very interesting slide. And always we have to look for primary in the other sites, as she mentioned.
Yes, ma'am. Yes, ma'am.
We have few cases being reported by us. Thank you, ma.
Yes, ma'am. The case is presented for
All
its
over.
rare.
Yeah.
Yes, ma'am. So can we go on to the next case, Dr. Divya? Dr. Divya from
Yes, ma'am.
Yeah, please share your screen.
Yes, ma'am. I will share my screen. Ma'am, are you able to see my screen?
Yes, Divya, please continue. Good evening.
Yes, ma'am. Good afternoon. I'm Dr. Divya from Sri Ramchandra Institute of Higher Education Research. So this case is a boy with a persistent snoring. He's a 4-year, 6-month-old boy who complained of persistent snoring. His father was the informant, and a history of snoring was present for the last 2 weeks. And on further investigation, the father gave history of muffled voice, history of nasal twang in voice was also present. No other significant history was present. And then outside hospital, the child was evaluated and he was treated with oral antibiotics because they thought it could be acute tonsillitis. But still, it did not resolve. And his vitals were within normal limits. Pala was present. Oral cavity showed grade 3 tonsillar enlargement and dental caries. Subcentimetric cervical, axillary, inguinal lymphadenopathy was also present, and his systemic examination was within normal limits. Investigations, child had hemoglobin 10.9 and peripheral smear showed microcytic hyperchromic blood picture. All the other parameters were within normal limits. The imaging, the CT imaging, CT plane and MRI plane done outside showed bilateral bulky tonsils, and the images were not available. So the child underwent surgery and he underwent a right tonsillectomy. I'm not sure why they did right alone, because maybe they thought that the surgeon probably would have thought that the tonsil looked kind of abnormal, so they only took the right tonsil alone. And in specimen, we received right tonsillar mass. We received multiple gray white soft tissue fragments, altogether measuring 4 by 3 by 1 centimeter. And on histology, we saw this picture. This is a low power magnification where we can see these blue areas and pale areas. On further high power, we saw these monomorphic medium-sized cells with scanned basophilic cytoplasm, clumped chromatin, and multiple small nucleoli was present, and scattered mitosis. Mitosis was actually increased. And apart from that, we saw all these tingible body macrophages with nuclear debris. So based on all these pictures, this resembled a typical starry sky pattern. This is a starry sky picture. We gave the diagnosis as non-Hodgkin's lymphoma, and we informed the clinician that this could be Burkitt's lymphoma. Only after IHC, we will give the final diagnosis. The immunohistochemistry, it was positive for CD45, 20, CD10, BCL6. CIMIC was positive, Ki67 was 100%. And CD3 and CD5 was just present in the background area, not in the neoplastic cells. And the cells were negative for BCL2, MUM1, cyclin D, ruling out other possibilities. And we gave the diagnosis based on morphology and IHC pattern that it is in favor of Burkitt's lymphoma of the right tonsil. And following this, the tissue was sent for molecular testing, where the translocation for chromosome 8 and 14 came, which is classical of Burkitt's lymphoma. Now, subsequently, a bone marrow aspirate was done, which was normocellular marrow. Bone marrow biopsy was also done, which was also normocellular. And following this, a radiology was done where the PET CT showed increase in the uptake in the left side, and the right side tonsillar bed following surgery showed an uptake, but left side had more increased uptake, left tonsil. So just a few words about Burkitt's lymphoma. So in the 5th edition of the WHO classification of lymphoid neoplasm, the Burkitt's lymphoma is defined as a mature aggressive B-cell neoplasm composed of monomorphic medium-sized cells with basophilic cytoplasm, multiple small nuclei, and it's a germinal center B-cell immunophenotype with high proliferation index and MYC rearrangement with an immunoglobulin gene partner. And the key points is that this is of 3 types: endemic, sporadic, and immunodeficiency related. The endemic is mostly seen only in children. It's an African variant. It is associated with EBV infection. Sporadic and immunodeficiency are seen more in adults, though they are seen in children also, but more commonly in adults. And immunodeficiency is usually associated with HIV/AIDS. And this tumor has a trimodal age pattern, can be seen in young children, in 5th decade, and in the elderly. And the extranodal sites commonly are in endemic cases, you'll see in the jaw, orbits, retroperitoneal area, bone marrow. In sporadic, it is mostly in the GI tract, head and neck, pharynx, tonsils, and sinuses. Immunodeficiency, again, GI tract and bone marrow. And morphology is the key for this. And when you come to the pathogenesis, it is mostly 8-14 translocation is most commonly present, whereas less commonly we can see translocation in 2-8 and 8-22 translocation. And the break, so how do we differentiate between this sporadic and in the endemic? Is that in sporadic the break point is found in the class switch regions, whereas in endemic Burkitt's lymphoma they tend to lie within more of a 5' VDG sequences, whereas in immunodeficiency breakpoints are seen in both the sites. And differential diagnosis for this will be DLBCL, which will again be positive for BCL2, high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement, which will again be positive for BCL2 IHC, which is negative in our case. B lymphoblastic leukemia lymphoma, which will be positive for again BCL2, PDT. Plasmablastic lymphoma, which will be positive for MUM1 and CD130. And these two are 2 case series which they did, tonsillar lymphoma in a children age group, which was done in the US, and the second one was done in the European population. They found that in tonsillar lymphomas, the most common will be the Burkitt's lymphoma. And before this child had 3 cycles of chemotherapy. Since he's a young child and his LDH was within normal limits and it was a localized tumor, he responded well, and it is the children are usually highly chemosensitive, so the response is very good in this child. He has a better prognosis. Thank you.
Thank you, Dr. Divya. And what's happening to the other tonsil?
Ma'am, I don't know why they removed only one tonsil, but the other tonsil now it's responded well, and I think they're just put 3 cycles of chemo. They've not decided on what to do. The response is good, but so
Burkitt's, what is the incidence of Burkitt's lymphoma in the tonsils?
ma'am, tonsils is very rare, ma'am. Incidence is usually, if it's a lymphoma, it is usually Burkitt's lymphoma, but incidence of Burkitt's, I need to check now.
Okay. So any cases open for
Maybe
discussion?
10 to 15% of sporadic Burkitt's lymphoma tend to occur in tonsils, ma'am. But apart from that, there's not much report on how many cases exactly in literature. In
So
fact, over a period of time, they took even the series which they did, they took over a period of 20 to 30 years. They collected around 80 cases of lymphoma and tonsils, of which they found Burkitt's lymphoma to be 50% of cases were Burkitt's lymphoma. That will be around 40 cases over a period of 30 years.
So the patient did not have lymphadenopathy anywhere.
No, ma'am, subcentric lymphadenopathy was present, but they thought it could be just a viral because of the tonsillitis again. Sorry. Subcentric lymphadenopathy was present, ma'am.
Where? Site?
Site was in the, just a second, ma'am. Yeah, in cervical, axillary, and inguinal lymphadenopathy was present, but still they didn't suspect it to be only on the CT was done outside, ma'am. So we did not have the images. So the patient came after he did not respond to oral antibiotics. He came to us.
Okay.
So they thought, the clinician thought that it could be just a tonsillitis, and they proceeded.
Thank you, Dr. Divya.
Thank you, ma'am.
Case is open for discussion. Any
Abdomen is not only the Pandora box. The whole body is like a Pandora box. We can get some magical events always.
Yes, sir.
Okay, ma'am. So that comes to the end of the presentation, ma'am. So that we thank you all the presenters for your excellent presentation and all those who logged in. And anyway, I'll post the synopsis of the city pathology meet, ma'am. Thank you so much. And so we come to the end of the 45th city pathology meet. We'll meet maybe towards the end of the year.
Thank you. We appreciate the same enthusiasm from your first City Pathology Club from Valarmati.
Ma'am, it's all everybody together, ma'am. It's a teamwork.
No. You really needs an appreciation, pat on your back.
Thank you, ma'am. Thank you so much. Ma'am, we close. Thank you. Have a good evening and a great weekend. Thank you. Thank you.
Ma.
Thank you all.